In 2019, the World Health Organization presented a series of 6 webinars of around 40 minutes each on the subject of leveraging public financial management for better health. These have now been transformed into a series of visual podcasts which are free to download on the WHO website. Recorded in May 2019, this first podcast is about the role of public financial management systems in the health sector, which covers the importance of compulsory funding in universal health coverage, the main challenges encountered in the health sector, and examples of successful reforms in African countries. We hope you enjoy this podcast.
We have a distinguished group of speakers with us today. We are very pleased to welcome Jo Katzen, Coordinator Health Financing at WHO Geneva, Switzerland. Our second speaker is Helen Barrois, Senior Health Financing Specialist at WHO Geneva, Switzerland. Our third speaker is Neil Cole, Executive Secretary at the Collaborative Africa Budget Reform Initiative. Jo Katzen will provide an introduction on public funds and universal health coverage. Jo, please go ahead.
The aim of what I'm going to try to do in the next 15 minutes is really to set the stage for the discussions today and the future webinars, providing a kind of motivation of the issues of why we're interested in PFM, why thinking about universal health coverage and health financing in a sense leads to the conclusion that PFM matters if we're serious about these objectives. I'm sure most of you in the audience are familiar with the concept of universal health coverage, really that everyone is able to get the services they need of good quality and without fear of financial hardship. To make that practical, we use the expression of moving towards UHC, which effectively means making improvements in some combination of those objectives of improving equity and service use quality and financial protection. And in that sense, regardless of your starting point, we believe that all countries share those objectives to some degree. Based on that, when we think about also the concept of UHC and what it brought essentially to public policy, it was really a shift from, say, the original approach, which goes back to Bismarck in the 19th century in Germany, where coverage was really an entitlement linked to your employment status for the purpose of improving labor productivity. And the shift towards UHC is more of coverage as a right, which can be a right for all people, for citizens, residents, and so on, and not as merely an employee benefit. And beyond just the kind of the legal ramifications of that, the kind of policy implications in health financing is that this has implications for thinking about both revenue sources and, again, in this shift in the basis from entitlement to employment to simply having entitlement based on being a person. This is an overview depiction of how health financing fits within the overall health system, the components of what we mean by health financing, and then at least conceptually some of a way of framing the goals and intermediate objectives of UHC. So on the left side and in the square box are what we often talk about as the functions and policies of health financing. So the functions of raising revenues, of pooling those revenues or accumulating them on behalf of some or all of the population, and purchasing of services, which in its most basic fundamental sense simply means the allocation of those pooled resources to the providers. Benefits are really the policies around the entitlements and obligations of the population. So what are people entitled to and what obligations do they have? For example, are they required to make a copayment or to, for example, first visit primary care before seeing a specialist? So that type of arrangement. The point is, as we try to convey on the left, that health financing does not operate independently of the rest of the health system, but needs to be linked to that. At the far right of this picture is just a framing of UHC, so use relative to need, financial protection, and quality. And then we define specific intermediate objectives of health financing for UHC. So what are the pathways by which financing arrangements can influence progress on those objectives? And again, through the influence on equity and the distribution of resources, on efficiency in the use of resources, and on transparency and accountability. So the extent to which, for example, people understand their entitlements and are able to realize them in practice. So this was really just kind of an overview of the basics around UHC and health financing. And now I want to come to kind of more specifically of the motivation about why public funds matter. This is just a depiction from our Global Health Expenditure Database showing the association between public spending on health, which is on the x-axis, so public spending on health as a share of GDP, and the extent to which systems are dependent on out-of-pocket payments. And so on that axis is out-of-pocket spending as a share of total or current health spending. The size of the bubbles, as it says there, reflects per capita GDP. The other point we see here is that, more of the larger bubbles are to the right-hand side of this, and this shows what is to be expected, that richer countries, in a sense, have richer governments relative to the rest of their economy and are able to spend more on health from public sources than is the case in poorer countries. So the bottom line is the more public spending can be made on health, the less exposure to financial hardship. The other point of this is that you see it's not a linear relationship, and in fact there's a lot of variation around that trend. Some of that are data challenges, but some is the real point that it's not just an accounting problem, that policies and implementation matters, and countries with similar levels of expenditure can get very different results. Based on the experience of countries, based on the data and what we see in practice, we have defined basically three what we might call signposts or guiding principles on health financing reform for UHC. One is driven very much by what you see in that previous chart, that basically it's important for countries to move towards a predominant reliance on compulsory funding sources. And that really means some type of tax or public revenues. It's not indicating at this point what type of tax that is. Other features relate to or important principles are to reduce fragmentation in how funds are pooled, because that enables more redistributive capacity, more financial protection from any given level of funds. And last, and very importantly, and we'll come to at the end of my talk, is strategic purchasing, or simply the allocation of resources to providers based on data around both provider performance and population health needs, as well as ensuring that funds are used efficiently and expenditure growth is managed. So this is really three critical principles. I will mostly focus on the first, however. So in a way, the implication for low and middle income countries, it's quite a challenging situation, because it's important to mobilize tax revenues to move towards having predominant reliance on compulsory sources. But we also know that low and middle income countries are characterized by mostly informal economies. And it's very difficult to mobilize revenues in that setting. That in general, low income countries might mobilize about half the revenues as a share of GDP than higher income countries do, purely in terms of their tax systems. But the critical point as well is that they can't raise very much from direct taxes, so that the employer-employee contributions or income taxes levied on individuals. So most of this money is likely to come from things like value-added tax, indirect tax, consumption taxes, and so forth. So that's generally the main source, which leads us to the importance of the dialogue with finance, not only on the level of finance, but the whole issues in the budget process, and recognizing that most of the money that needs to be used will come out of general budget revenues. The challenge is not just then to raise the money, but actually to spend it well. And since it's going to be general budget revenues, the critical challenge is how do we match those funds, the funds coming out of budgets, to the priorities that the country has, whether it's priority specific services or priority population groups. And very often this is difficult, as we'll hear, if budgets are organized by line items, if they're organized by paying salaries and medicines, then even if you do a nice exercise to show what your most cost-effective interventions are, there's not a mechanism to match your resources to those priorities. So this then requires taking some actions within the health sector, things like ensuring there's autonomy for providers, giving more control to managers over the management of their resources, and then dealing with some of the basics of PFM that we'll hear about around things like having a realistic budget, a reliable medium-term expenditure framework that has a connection to the annual budget process. So it's very clear, and one of the slogans we like to use is that while public funding is important, no country can just spend its way to UHC. It's critically important to use the money well, to use it to drive efficiency and equity gains in the system, and what we call strategic purchasing is a critical strategy for that. And as we heard, one of the webinars will deal with the links between PFM and purchasing. But really what we're talking about again is that we're linking the allocations to information, right? To data on provider performance or the health needs of the populations they serve. Thinking about another way is in a sense moving away from the extremes of either extreme government hierarchical control or extreme market forces. And so one is what we see in many countries where government budgets are quite rigid. They might be based simply on the number of staff or hospital beds or so on, and very little flexibility of managers to move funds across to respond to changing circumstances. And the other extreme to move away from is providing what might be seen as a cashier function, just paying the bills that are submitted by a provider. So really strategic purchasing is about moving away from both of those extremes. So in a sense, the summary is really that the path to universal coverage really runs from domestic general budget revenues through PFM arrangements. We see coverage as a right as the foundation for UHC, and that has told us, from the evidence that it has to be a reliance on public compulsory sources, that voluntary prepayment, individual contribution doesn't work very well. That means, again, in the context of low and middle income countries, that it's going to be general budget revenues and predominantly from indirect taxes that will be the main source, given high degrees of informality in the economy. Wanting to then apply strategic purchasing methods to those general revenues is key for sustainability. And in order to get there, it then requires the alignment between the PFM mechanisms and health financing policy to enable this to happen and ensure we still have accountability for the use of public funds, but it's flexible and focused on results.
We will now turn to Helen Barrois, who will provide an overview of public financial management challenges in health.
So in this presentation, I will focus on providing a rapid overview of common public financial management challenges that we observed in the health sector in low and middle income countries. So I would like to start with a basic definition of PFM, probably for those who are not really familiar with the term and with this field of work. So just to say that PFM is really the set of rules and practices that govern how public resources are first allocated, then used, and then accounted for. So PFM is really this set of rules and practices that govern the allocation, the use, and the reporting of public funds. In general, PFM systems often serve different functions across government sectors. And I wanted to recap them here just as an introduction. The first thing that I think is important to remember is that PFM systems should ensure predictability in funding through, as Joe mentioned, the introduction of multi-year budgeting approaches. This is one way indeed to ensure predictability in the level of funding. Second, PFM systems should also allow, to some extent, a strategic allocation of the public resources, strategic allocation of resources across the different policy priorities of a government. Third, obviously, PFM systems should also help us to ensure that there is an effective and efficient use of the public resources that are injected in general in the development of policy priorities. Last but not least, we want also PFM system to guarantee a good financial transparency and accountability towards results. So in this first slide, I just wanted to remember all of us that in general, this is the key functions or the key goals, if you wish, of public financial management systems. But PFM is specifically important for health and for the response towards universal health coverage. And it's specifically important in the sense that each step, if you wish, each step of the budget cycle, from budget formulation to budget monitoring, has a critical influence on the level and the quality of public spending in the health sector. And this will obviously matter for results. So in the first stage, budget formulation, we'll come back to that. Budget formulation is really important because it will influence basically how public resources are allocated to sector priorities. So obviously, if you have a budget which is not targeted to the right services or to the right needs, you won't get the result that you want, okay? The second phase, budget execution, is also very critical because it's about spending public resources, and specifically, as Joe mentioned, in the health sector, it's about how we pay service providers. And typically incentives, if they are well defined, incentive in provider payment mechanism will matter for results. So very critical phase for. Third phase, budget monitoring, obviously also very important for us. It will tell us how much is spent in our sector and also how much we get through the resources injected in the health system. So in this slide, I just want to reiterate the importance of the first stage in the budget cycle, so which is budget formulation. Budget formulation is indeed essential, if not probably the most fundamental stage in the budget cycle for efficient spending in the health sector. If you have budget proposals that are not strong enough, as you said, not realistic, badly prioritized, ill-costed, not aligned with the needs of the sector, it will contribute to weak execution and ultimately to poor results in the sector. So really a fundamental phase for the implementation of UHC policies, if we may say so. So to recap here, I just wanted to highlight some of the common challenges that we've been observing in low and middle income countries in the development of budgets in the health sector. First, as I said, lack of predictability, sector doesn't know in advance how much it will get. Second, budget proposals are misaligned with the resource envelope. Unrealistic cost estimates don't make things really implementable or really realistic in terms of what do we propose as a sector in terms of budget needs. Budget proposal, sometimes some sort of a shopping list with no clear prioritization of expenditure within the sector envelope. Another aspect, and we will come back to that in the next webinar session, budget structure, often too rigid, budgets that are defined following an input-based approach. It's a constraint for the sector. There is no clear link with the results that we want to achieve in the sector, and they are very rigid to be managed. Last but not least, the multiplicity and the fragmentation of the different funding streams in the sector hinder, if you wish, the ability to really budget in a comprehensive manner in the health sector. So these are some of the critical issues that we see in budget development in the health sector. We will come back to these budget formulation issues in more details in the webinar session in June. So with that, I would like to move to the second stage of the budget cycle, focusing on budget execution issues. So as you know, I'm sure, budget underspending is a chronic issue in the health sector in most low and middle income countries. So for the work that we've started to do on this topic, using a sample of 30 African countries, what we observe is that on average, health budget execution is systematically lower in comparison to overall budget execution. Basically, this is what you see on the graph on the left-hand side, and the health budget execution part is in orange. On the right-hand side of this slide, you see that also health budget execution is actually decreasing in African countries on average between 2008 and 2016. We also have evidence that we are in the process of putting together that health budget execution is lower in the health sector than in the education sector. So really something that is specific to our sector and that needs to be addressed seriously. So underspending is often associated with what we often hear there's low absorption capacities of ministries of health. But we think that is very critical, if you wish, to really open this black box of low absorption capacity and really to unpack the different causes or the different sets of causes that can help understand better understanding issues in the health sector. So the first set of causes that we unpack here, that are on the left-hand side of this slide, are causes that actually happen before funds are disbursed, are released. So what we call here upstream expenditure causes. So things related to the formulation of budget, as we mentioned earlier, poor cost estimates, inconsistent financial management rules across funding flows, and so on. But there is also another set of causes that are more directly related to the management of expenditure. So what we call downstream expenditure causes, so things related to cash requests or misaligned budget releases, limited financial autonomy of health service providers, things that Joe mentioned earlier. And in these two buckets, so on the left-hand side, upstream causes, on the right-hand side, downstream causes. So in these two buckets, some causes are actually linked to ministries of finance duties. For example, the late and misaligned budget releases, this is something that the ministries of health is not in charge of. This is direct duty for ministries of finance. There is also some of the causes that are directly in the hands of ministries of health. Cash requests should be issued by ministries of health on time and in alignment with what was approved in the finance law. And there is another set of causes that would actually require a collaboration, a discussion, a dialogue, a joint response between finance authorities and health authorities. When we speak in terms of limited financial autonomy of health service providers, that could actually result in low execution of budget because budgets are too constrained and they don't have the authority to manage them. It would require working together, health, finance, and probably also with local authorities to redefine some sort of a framework to provide more financial and managerial autonomy for service providers. So with this framework in mind, we think that is very important in any country context to try and unpack these different set of causes for you to understand better how can maybe a joint action plan can be defined between finance and health authorities to really address this critical issue of underspending. So as a recap, how can ministries of health can more effectively engage in the PFM agenda? So through our work, specifically in the African region, but I think this is applicable for other regions of the world, and I'll share with you the results of this publication that will be soon released. We have actually identified 3 distinct areas of possible engagement for health authorities in the PFM agenda. The first one, which is displayed now, it's about general PFM reforms, if you wish. Ministries of health should be more aware, more interested, probably, by general PFM reforms. Because general PFM reforms, they are important for the sector. Again, if we take the example of multi-year expenditure framework or multi-year budgeting approaches, these reforms are important for the sector because basically they will improve, hopefully, the predictability in the level of resources that we will get in the sector. So we should be more interested in monitoring the implementation of these reforms by finance guys. The second area is more directly related to PFM reforms that have direct implication for the health sector. We do believe that health ministries should be directly engaged, for example, in the design of budgetary programs for the health sector, because they are best placed. Budgetary programs will be better defined if health ministries are directly engaged, if you wish, in the design of the content and the boundaries of these programs, better than probably if other or finance authorities are directly in charge of that. Third area, so we do also see that there is some specific PFM interventions that should be defined specifically for the health sector. And for that, ministries of health should actually take the lead in the definition and the implementation of these specific interventions. One thing that we mentioned earlier, Joe and I, is this idea of developing a refined legal and institutional framework for providing more financial autonomy to service providers. This is critical from a health sector perspective. Ministries of health should take the lead in defining these new frameworks in collaboration with finance authorities and often with local governments. So this is the third distinct area where we see that ministries of health should be more directly engaged. So to close my presentation, I just wanted to briefly recap what we as WHO do in this PFM health agenda. We try and provide some conceptual guidance. We developed several papers that we will share with you that actually try to provide clarity on the definitions, the key concept, but also on these kind of interactions between PFM, health policy, and health financing systems. Second, we consolidate global and regional knowledge. One example that I display here is a repository of health budget documents that we compiled together and which is now posted online, which is a repository of health budget documents for more than 100 low and middle income countries. Last but not least, we do provide direct country support on PFM reform, specifically in the health sector. And so this is one example here of the work that we do in Burkina Faso, but we do the same type of work in 12 countries currently, where we start with analytical work and we then do provide direct technical assistance, for example, on the implementation of program budget in the health sector.
We will now turn to Neil Cole, who will provide country examples of successful PFM reforms. Neil, please go ahead.
Thank you very much, Ileana, and greetings to all the listeners. I want to start by sharing some of the common challenges that countries have been experiencing for, I think in many cases, for over a decade or more. And these challenges are often what success is measured against. So first up is revenue forecasting and estimates of expenditure. And I think for many countries, there's been weak forecasting that has been coupled with unreliable flows of funds. The second is a challenge of aligning and ensuring that the plans that countries have, whether it is medium or longer term plans as articulated in the national development plans, and also now more increasingly you have the sustainable development goals as a plan that a country has put as what it wants to move towards. So the problem of the alignment between those medium to long-term plans, and then articulating that in the sector plans, feeding that into the budget process, and then also implementation. Extra budgetary expenditure has been a challenge for many countries, and this is mainly located within state-owned enterprises, and it really refers to spending that has not been included in the budget. Political interference in allocation decisions has been a challenge, and here I'm not speaking about the importance of the political oversight of the budget process. This refers to the process that often runs parallel with the budget process, where the process is not transparent and it is not covered by the rigor of the decision-making processes. Unsustainable borrowing is now becoming a major concern for many countries, especially those countries that are now facing debt distress. I think corruption is a well-known problem, and we certainly see great inefficiencies within health and education expenditure, and also in infrastructure expenditure that is taking place. And corruption is one of those major inefficiencies within public finance. The weak accountability, and here I'm referring to the feedback loop from the legislator and the extent to which the recommendations by the legislator, having examined audit reports, the extent to which those recommendations are then implemented by spending agencies. So these are some of the major challenges that countries have been experiencing, and challenges that have been around for a while. And what we need to be looking at is how the reforms that are being implemented, suggested for countries, how these reforms are tackling some of these challenges that I've identified. So you have listed some of the more common PFM reforms, and in thinking about PFM success stories, it's not just about whether a country has adopted these reforms, but whether these reforms have contributed towards more functional public finance management processes, systems, as was defined by Eileen, but also whether these reforms have contributed towards better public finance decisions. My favorite one on this list is Treasury's single account, because the Treasury single account is one of those very basic systems reforms that countries need to put in place, and it is essentially about knowing how much money a country has on a daily basis to spend on public services. And a lot of it is about improving the coordination between your central bank, your treasury, your revenue authority, and in cases, your commercial banks. Many countries, as they've tackled this reform, have discovered lots of idle cash, especially idle cash that line ministries deposit into commercial banks, and idle cash is really an inefficiency because those funds could have been used for public services. Program-based budgeting and medium-term expenditure frameworks are the two that have probably interested the health sector the most, and as was mentioned before, medium-term expenditure frameworks is about extending that horizon, improving predictability, but also pushing some expenditure that may be unaffordable in the first year, pushing that into the second and the third year. But provided that the outer year estimates matter and that the outer year estimates are included in the future planning. Program-based budgeting is one where especially health ministries, but also other line ministries have been able to better articulate the outputs and the outcomes and arrange that in a set of programs, such as improving maternal health, etc. Procurement's also one that has been of significant interest to the health sector, partly because of decentralized procurement systems where you allow health facilities to procure their own goods and services. But it's also been where many cases of corruption has occurred, such as paying 3 times the cost for a dialysis machine, which means that you're unable to buy 5 more. Integrated financial management systems, I mean, these have been the ones that have probably been, in my view, the most problematic in terms of what countries and development partners have spent on this reform. This is the most expensive reform for African countries, but it's also one of those systems that have been underutilized. And also where difficulties with the system has not necessarily resulted in fixes, but have resulted in the introduction of an upgrade. So, you have a country like Lesotho that is on its 10th version of its IFMA system, but many of the modules of the system are still not used. So the point to make is that the measurement of success is not only about the adoption of the best practice, and the reforms that I've listed on the previous page, can be categorized as best practice PFM reforms. A successful PFM system needs to be measured also on whether the system is functioning well. So I want to focus on a PFM success story, and the country that I want to use is one that I'm familiar with, as would have been stated in the intro, and that is South Africa, and cover 3 of what I think are the critical successes in the PFM reforms and public finance reforms. The first is the single budget allocation process. I think what this has done is to ensure that the budget that is prepared is off the back of a transparent and a comprehensive budget process that has delivered a comprehensive budget. And one can also, in terms of the definition of a credible budget, say that it has delivered a credible budget and one where the budget is delivered as a medium-term expenditure framework, with the first year of that framework, the budget that is to be appropriated. And by tabling the medium-term expenditure framework, which includes the outer year estimates, those estimates are then out in the public, and in a way, the new budget process has to take on board those outer year estimates as the starting point, because they have been made public. I think as a single budget process for South Africa has certainly made the spending decisions more affordable, in that you have consolidated all the budget bits that have come in from different line ministries. So where you are considering an increase in health allocation, this has to come from a known area of fiscal space, which could be through reprioritization, and the place where that reprioritization happens is within that single budget process. A single process also ensures that there's buy-in from both the technical and political stakeholders, and many countries have designed their budget process so that there is that interaction between the political oversight and the technical inputs that are provided, because ultimately a budget is an articulation of the policy priorities of the ruling party. It allows also for better decisions to be made, such as trade-offs. So if there is a decision that needs to be made between what is considered to be equally important spending priorities, the single budget process is there to make that trade-off. I think the second one, and this was touched on by Helen, is the medium-term expenditure frameworks. But the functionality of that reform is that the medium-term estimates do matter, or let's say the success of having introduced an MTF is one of them is that the medium-term estimates matter. And this has improved planning and implementation. It has certainly improved the ability of the South African government to implement programs over, or to stagger the implementation of a program over the medium-term period. So as illustration, the implementation of the child support grant, it was extended from 6 to 9 year-olds over the first year. In the second year, it was increased to older children, and in the third year and going forward, increased to children up to the age of 18 that meet the means test. And I think it's also a medium-term expenditure framework would be critical in thinking about how South Africa would go about financing the national health insurance, because it is about how you bring citizens into the scheme and how you bring on board other stakeholders, especially your private health providers. And in the case of South Africa, with the piloting of the NHI, that piloting and the expansion, it's best planned over a medium-term period where you've allocated resources, or the extent of the resource allocation in your second and in your third year and years beyond. The centralized procurement one is an interesting one, because South Africa moved towards a fairly rapid decentralization of procurement, and due to a variety of reasons, corruption being one of them, insufficient capacity and understanding of procedures, the country needed to roll back the decentralization of procurement. centralizing certain procurement, reduced corruption, and it was really a response to the mistake of too fast decentralization, and certainly something that many countries would need to think about carefully as they embark on fiscal decentralized systems that is accompanied by decentralized procurement. Questions around, is the capacity there? Has there been sufficient training and understanding in order to make a decentralized procurement system work? My final slide is maybe just to touch on some successes within public finance management and public finance in countries that CABRI has worked with. The first is the Gambia, where we have seen the lowering of environments. Environments is where funds are shifted from one line item or from one program to another line item or another program. And this can have very significant impact on health spending. Normally, when line ministries prepare their budget, they would prepare their budget by presenting the high priority expenditure items upfront, and sometimes leave off the things that they are aware are not going to be funded. And then in the implementation of the budget, funds are then shifted from those high priority items to the lower priority items. One of those low priority items is international travel. And if there are no rules in terms of, where funds can be shifted from or in what percentage, it is very likely that it's going to be shifted from high to low. And in the Gambia, that percentage of environments have been reduced. In the case of Nigeria, we've seen an improved conceptualization of capital projects through improving the relationship between the executive and the legislator. And this was a problem where the legislator was introducing, at the time of the tabling of the budget, they were introducing additional infrastructure projects that had not undergone the rigor of the conceptualization that happens during the budget process. And if we think here about health facilities, clinics, hospitals, etc., this can have a very significant impact on those projects that have gone through the budget process and those that are coming in, let's say, sideways. In South Africa, we've done work in improving the compliance with the standard chart of accounts, and that's essentially how you attribute expenditure in a standard chart of accounts. And then the final one is the Central African Republic, so a country that has just come out of conflict and still experiencing great fragility. The country was, despite having a very modern procurement law in place, was only spending not more than 3% on their investment budget, with the lowest percentage being the health ministry. And by breaking the problem up into its various causes, there's been an increase in spending of the capital budget. And this is mainly done through the training of line ministries in the procurement law, but also improving the coordination between the Ministry of Health and the Ministry of Finance.
Thank you for joining us for this first podcast. Please join us for our next one on budget formulation, available now on our website.